Before I jump into my story, first off, I really want to thank my colleague. I love that she identified patient voices in that manner, Julie, who went over a lot of the nuts and bolts. And as I present today on my story and the intersection of my story in the area of mental health innovation, I really want to remind everybody to remain conscious of the suggestions that Julie had. Those dreams need to become realities, and they need to become realities for everybody in our country. In British Columbia, home for me is in Vancouver. We're one of the tech leaders in Canada, and yet in healthcare in our province, we're probably one of the most lagging behind in a lot of the innovations being talked today, which blows my mind when we have Amazon and amazing resources and Google and Facebook and everybody in my downtown core, yet we don't have super awesome patient portals like Quebec just. I'm incredibly jealous. But I digress. I want to jump into some tangible reflection between my personal experience going through the mental health journey and some tangible suggestions that I think all of us can have in innovation and going forward and working in collaboration with patients. Before I can get there, I need to talk about what I relate to as the dark ages of my health journey. And I do recognize that when I start to talk about this, I'm talking about the 90s, I'm talking about the early 2000s. We didn't have digital health as a conversation. We didn't have mental health as a conversation in that time. So yes, take that into account. So I grew up in a suburb of Vancouver called Chilliwack. It's about an hour and a half away from the city. It's a quaint little town, about 60,000 people, and all of the stereotypes apply. At one point in my life, I grew up on a farm. I know how to milk a cow. You take a machine and you hook it up to the cow and the machine does it. I was a pretty outgoing, pretty joyful little boy up till about the age of 6, when my parents decided that they couldn't work together and they decided to get divorced. This was the beginning of my isolation. I put up my walls because although the difficult experience of divorce, in my situation, my mother decided to take out a lot of the frustrations that she was going through out on me. And quickly after the divorce, began abuse, and that abuse continued for a large duration of my childhood, actually straight through to grade 12. In mental health, we talk a lot about this back and forth between fight and flight, and this was my childhood, paired with wearing a mask oftentimes, particularly when I was in front of my teachers or when I was at shared doctor's appointments. I was the perfect bill of health. I was happy, healthy, functional. It's good to know that in a lot of abuse cases, especially ones that happen at home, we take for granted the normalcy that actually exists in life. I still had birthdays, I still had Christmas, family still came over. All of those things occur and abuse happens. And in my case, not only verbal abuse, physical abuse, but also sexual abuse. I'm not going to get into the details of that because that's not what we're here to talk about today. We're talking about a journey that I went on. And so there's not a lot to be said when I was experiencing the abuse because I wasn't getting care at that time. In fact, and especially as a guy in this situation, I didn't even have the literacy to pose the question. I didn't know how to ask for help. And particularly in abuse, that was because my abuser used very common tactics. Fear was a constant presence in my life. And that fear was created by a threat. Tell anybody and I will kill you. I'm not alone in this as a survivor of abuse. It's a very common threat that many children experience, both here in Canada and abroad. And it is certainly a large problem here in Canada. So I couldn't fight in the real world, but I could fight online. And this was actually my first experience with digital tools. But for me, it was in Azeroth, a World of Warcraft game with a massive multiplayer online community of friends really my family, around the world. This was really important to me because this was when I started to transition. In grade 12, I revealed the physical abuse that was happening, and through supports from my school, I got out of that abusive situation. I was living with my brother, who was 4 years older than me at that time. But I was self-medicating. I was still very much isolating because I still did not know how to ask the question. Like I said, we didn't talk about mental health. We talked about Louis the Lightning Bug, BC Hydro. Very few of you are probably familiar with this. He told us the power lines are dangerous. We learned that any time is train time. There was one railroad track in my city. I stayed away from that train. But nobody told me that if somebody's hitting you at home, here's what you need to do to get help. So I warred online to numb the growing symptoms that I was having for my mental illness. Of course, what I eventually ended up being diagnosed with, post-traumatic stress disorder, which is a fascinating diagnosis because I'm the jack of all trades of mental illness. I kind of have it all at some point, which is really interesting from what I now do, which is patient engagement and experience, is I have a high relatability to a large spectrum of mental illness. So in my young adulthood, standing here at 31, I had choices to make. And if I look back at the data, when I look at ACEs, that many of you might be familiar, adverse childhood experiences, I defy so many of those statistics. I actually stand here today, I'm an anomaly. Because if you know the data, I should have a substance use problem, I may have committed suicide by now, and I would not be here to tell my story. So it's an honor to be here today before you, because so many fellow Canadians who have a similar childhood experience to me cannot speak for themselves anymore. And I think it's important that we recognize that. As I move from the Dark Ages to what I want to call my Renaissance, I also want to respect that I have a privilege even to be here today as a patient advocate and somebody who innovates in mental health technology, and being white and being male. That has a number of privileges, where there's still thousands, tens of thousands of voices who experience mental illness in our country, who are young people, who don't have the opportunity to talk today. So let's also remember that. But let's talk about something much more personal than sometimes the silicon involved in technology. People. If we are going to innovate in healthcare, in the field of mental health, we cannot forget about people. There is amazing, incredible evolution of technologies coming. AI and blockchain, self-monitoring, the ability that an app can analyze everything you do on your mobile phone and then send it to your care team and they'll analyze and get back to you. You know the problem with that? You lack context of the person. And yet there's millions of dollars being put into that. Yeah, VCs get a little excited when they hear AI and blockchain and they get a little spendy, but we can do better. So connection. For me, it was first online. It was that my guild, my group of people who I battled with in Azeroth. And as I slowly found the words to talk about what was going on, it started to be my care team. My care team was there 9 to 5, Monday to Friday, and I got 1 hour a week with them every couple weeks. My real connection, my real community for care and for recovery was online. We talk about patient hacking, and mental illness and mental health isn't as glamorous as diabetes and building a dialysis machine from scratch, but we make online forums. They're not very technologically complicated, but even in this moment, they're saving lives in this country because they're reducing isolation, because they're reducing loneliness. And for me, at 11:30 at night, at 2 o'clock in the morning, it was that online forum and people with shared experience that I could reach out to, that I say, I can fight for one more day because there's a similar story here of somebody else in the world who's equally fighting. That meant a lot to me. The Renaissance. Some could argue that we are in the Renaissance of digital health right now. Through technology, we have an incredible ability to educate. And that was the founding element of the Renaissance. We have a great responsibility, not just to teach patients about their health conditions, but teach them about digital health technology. EMRs shouldn't be French to English-speaking Canadians. I should use it differently, shouldn't be Mandarin to other languages. I should be much better at French than I am as a Canadian. The Renaissance is this collaboration that can occur across all levels. When health information and awareness and knowledge is equal, all of us can participate. Julie spoke about that earlier today, that it's not a detraction from our current health system, but an advancement, a benefit of the health system when you can have eagerly engaged patients that want to look at the data. I have another privilege. My wife is a clinical pharmacist, so when I get my blood test reports, which I do get in BC, which is pretty cool, she can look at them, which is great. More privileges. So I have this little idea that I want to share with you today. What if, when we're building digital technologies, patients weren't a nice to have? What if they were required? In research, we're seeing this transition slowly take effect. CIHR, SPORE groups across the country, where patient collaboration is required in a lot more areas of research. This is very important for us as innovators, as health leaders, as technology leaders in this room, that they're not good to haves. They're requirements. I want to continue to brighten that idea with something that I'm sure many in this room are very familiar with, the IAP2 standards for engagement. We're pretty good at inform consult. We can do so much better at empower. For those of you not familiar with this framework, empower lets patients and general public be on committees where they actually hold power. I would leave us with a challenge that we're actually creating a new form of tokenism right now, putting patients on committees that hold no power, no decision-making. Patient engagement exists when there is a decision to be made in which the decision-maker is willing to have their opinion swayed by the input of those we're engaging with. If those two elements are not in the formula, we're asking patients a stupid question because you're wasting their time. If you're not willing to change your direction on the feedback that patients give, we are not even on this spectrum. Bad formatting aside, follow through on the feedback that patients give. Time and time again in my professional work, as much as I see within the patient advocacy community as a whole, is I see the same things being said and action not being taken. I love that example of the diabetes community and making a hack-together dialysis unit because patients in their need for change are highly efficient. In my work as a poor entrepreneur, Starbucks is my leading cost of business. And yet we can make a functional beta in less than 6 months and put it out to the public. An innovation that would cost $1 million for a nonprofit trying to be in the tech business to launch an app. We need to start finding out where the partnerships lie in this country as government, as major industry lays the highways that is going to lead to our digital technology revolution, our renaissance. We need to make sure that interoperability is part of that highway, because that highway alone isn't something that patients on a day-to-day really use. Yes, we need EMRs. We need those tools. And the sponsors of this conference are some of the leaders in our country in doing that. But if the social innovators can't come in and connect to the APIs and have interoperability, the ones that are already working with patient communities and the general public, if we can't innovate with those platforms, then we're going to do ourselves a disservice. So follow through. I need to close, but I want to reflect back at the very beginning. The childhood me. The problem is that speaking here today, there are still an unknown number of children in our country who have similar stories to the brief one that I have shared with you today. They do not have a voice. But they have something different than I had in the 90s and early 2000s. They do have digital technology now. How can we better promote not just health to the population, but how to access health? I think the question that came up to the panel before, how do we talk to those 14-year-olds? Mental health is an important area of health for that population. And we need to tailor our solutions in the mental health community. That is critical. The WHO classifies neuropsychiatric disabilities as the third leading cause of disability-affected life years. We can't forget that when we're building these innovations. Mental health can no longer be the abandoned child of healthcare, especially in the wake of the opioid crisis right now. We can do better. We have the leaders in this room that can make functional change in mental health. If we collaborate, if we meet the basic needs that patients in mental health are looking for, to be listened to feel connected, to feel respected, and to have a non-judgmental environment that they can reach out to and have their questions answered and be heard. These are all basic needs, basic things we can make. As I said before, digital forums don't cost millions of dollars, but can save lives. This room can save lives, and I thank you.